How you doing, guys? Welcome to the Onsite Club online. I'm Steven, I'm an officer in training, and this is Megan, she's an
Hi.
officer.
Hi.
Today we're gonna kind of piggyback on the whole week and talk about now AS misalignments. So Marcos and Patrick in one of the previous videos talked about PI misalignments. So now we're gonna talk about specifically AS misalignments. So what happens with an AS is that the ilium is gonna rock anterior and superior, which is why we call it AS. So what happens is it rocks up the articulation. So this articulation is the sacroiliac joint. It's an ear shaped, so auricular shaped. So we're talking up the articulation is AS. So with the AS, we can also have what we call a married listing. So an ASIN. So it's going to rock anterior superior, and also it's going to go internally. The reason we say it's married is that both of them do the same thing. They both go up the articulation. So the way it's shaped, since the IN is going internal, but because of the shape of the joint, it's also going slightly up. So now we have anterior superior and internal, so the ASIN. So they both do the same thing. They're going to cause a hypolordosis. They're going to make the leg longer, and they both go up the articulation. So then we have a divorce listing or a mixed listing of an AS, so anterior superior, and then EX, which means it rotates externally. So the reason they're divorced is because the AS goes up the articulation while the EX goes down the articulation. So when we're looking at divorced listings or mixed listings, what you have to do is reference the X-ray, and the subscript is going to tell you which one is the major component of the misalignment. Okay?
It's important to note that an ASIN and ASEX are not going to happen one more than the other just because they're called married and divorced listings. It's just that the way that they move are similar or not similar.
Okay. So when we're looking, when we first start, when we're analyzing the patient, we're doing our 5-step approach to the Gonstead system. We're going to start with palpation. So we're going to do static first. So static palpation, you're going to just be palpating for tight muscles, any edema, any tenderness on the patient. So since the ilium rocks anterior superior, what you're going to see with an AS only is there's going to be edema at the bottom of the joint. So it's about a 3-inch joint. It goes from maybe S1 to S3. So at the bottom of the joint, you're going to see edema for an AS. So, and you palpate there, it'll probably be a little tender for the patient. If it's an ASIN, the IN, you're not going to see any edema on the posterior aspect of the joint because it rocks internally, so it's closing this down. But there will be edema on the anterior aspect of the joint. So you're not going to be able to see it, but maybe the patient will say that they have groin pain just because of where the edema is. So then the ASEX is going to rock anterior superior and also externally. So with an EX misalignment, you're going to see edema anywhere along the joint, but because it's an AS, you're going to probably see more edema at that inferior aspect of the posterior part of the joint. Okay, so now we're going to do motion palpation. So all we're doing is you're going to place 2 or 3 fingers on the joint. So I like to put 1 finger on the sacrum, 1 finger on the ilium, the PSIS, and then all you're going to do is rock back and forth. So if I'm rocking laterally, it's going to close the joint, and the PSIS should come up. Okay? So if I rock laterally and the joint doesn't close, then I'm thinking it's an EX because it's stuck open. And then if the PSIS doesn't rock up, I'm thinking PI because it's stuck down. Okay? And then vice versa. When I rock medially, it's going to open this joint, and the PSIS is going to go down. So if the joint doesn't open, then I'm thinking it might be an IN because the joint is closed, the joint space is closed. And if the PSIS doesn't go down, then I'm thinking an AS because the PSIS is stuck up. Okay? So now for visualization on the patient, the different misalignments are also going to present themselves on like the gluteal fold changes. So if we take Megan, okay, so always ask permission before you even touch the patient.
Yes.
So do I have permission to
Yes.
do it? Okay, so what I'm doing is I'm going to take my fingers and I'm going to just go down to the bottom of the glute and then rock up, and then go up a little bit and compare the heights. So the AS is going to cause the gluteal fold to be higher and the PI is going to be lower. So since we're looking at the AS is going to be on the left side in Megan's case. The IN and the EX, you're not going to be able to see it too well here. You're fine. But the IN, since it's rocking internally, you're going to see a more flat glute. Okay, with an EX, the glute is going to be more peaked. So it's going to be more elevated. So these are things when the patient has a gown, you'll be able to visualize these things a little bit better. Okay? So now we're going to do motion palpation with Megan. So I'm going to palpate both sides and I'm comparing one side to the other. So they can both be a little bit fixed, but if they're both moving exactly the same or relatively close to each other, then we're not thinking that it's fixed. We're comparing one to the other and not comparing her to anybody else. Okay, so I'm going to locate her PSIS. Here. I'm going to put a finger in the whole joint. Okay, and then all I'm doing is feeling for the motion. So when I rock her laterally, the joint should close and the PSI should come up. When I go medially, it should open and it should rock down. Okay, so close, and PSIS goes up, and open, and PSIS goes down. So now I'm going over to the other side. So same thing on this side. I'm going to locate the PSIS. Okay, so I'm going to take her laterally. So the joint should close and the PSIS goes up. Then I'm going to go medially. The joint should open and the PSIS is going to go down. Okay? So now we're going to do So now we're going to show proper patient placement and how to execute an AS, an ASIN, or an ASEX push move. Okay? And Megan's going to demonstrate that.
For an AS listing, you're going to be contacting the Gonstead eminence, which is just above the acetabulum. So to locate that on your patient, you're going to come to the PSIS and just come 2 inches inferior and 3 inches lateral. And then you're just going to take your contact there. So I'm going to have my patient come. It's important to make sure your patient is in a neutral position. You want the spine to be neutral as well. You don't want any twisting of the spine or your patient to be uncomfortable. So leg is up straight, knee straight, hip, back, shoulder, all in alignment. You're gonna bring your inferior shoulder slightly inferior and anterior, and just to make sure they're comfortable, just realign the pillow for them. So we want skin to skin contact, so I'm just gonna pull this down a little bit, find his PSIS, and for an AS listing, we're gonna come down 2 inches and then lateral 3 inches. So for an AS, we're going down the articulation because it's rocked anterior superior, so we're trying to bring it back down. So my tissue pull is going to be inferior, and then with my piezoform, I'm setting that in. We're gonna put our stabilization hand on the patient's shoulder and just stretch it out to the opposite side of the bench, but without twisting the patient. We're just trying to take out the slack. I'm gonna roll my patient over and plant my ASIS on their greater trochanter. And then my thrust is just down the articulation. We're always going to be moving the bone along the disc plane line. So for this, it's going to be at 45 degrees along the SI joint. Okay? For an ASIN, the joint has rocked internally and down. So for this one, we're trying to push it back out. So again, we're going to be contacting the Gonstead eminence. We're going to do a tissue pull in, and then we want our hand up to push it external. Again, I'm going to roll my patient and land, and then the torque is going to be down the articulation. Okay, for an ASEX, our ilium has gone down the articulation and external, so we're going to try to push it back in. So I'm going to take my tissue pull down and medially, and then we want our hand down the articulation to push it back internal. And now we want our adjustment to be up the articulation. Okay? For stabilization, I'm going to come to the other side and show you how you stabilize the patient with your legs. So again, you're going to get your contact. You're going to roll your patient, and you want your ASIS on your greater trochanter, and you want your body to be in alignment because you want to protect yourself as a doctor, and you don't want to do a body drop like this. It's going to cause pain to you, and it's going to cause pain to your patient. So you want your body straight, and the stabilization is into the table with your whole body. You see I'm doing it right because you saw the table moving back. So you know my weight is going into the table and into that adjustment spot. Okay? Anything to add?
A good way to practice this, if you don't have a person, is to get a peanut ball, and it's honestly how I practice it when I'm by myself. And you do everything the same. So I imagine this is the patient's shoulder and this is the patient's hips. So when I do it, I take my tissue pull the same way. I'm going down the articulation. I set my stabilization leg, or my front leg. I set my other leg, and I'm stabilizing the patient's hip. And then I just do the thrust as if you would normally, down the articulation and do it stabilization. So it's a good way to just practice the mechanics of the movement. So that way, when you get to actually practicing with a person, you have all those little steps down, and you don't have to worry about so many things. It's just focusing on plane line of the disc and how you're going to torque and the line of thrust. Okay?
All right. Thank you.
Thank you.